Good evening, everybody. Welcome to the Community Memorial Health System Speaker Series Online. I'm Dr. Alison Shuman, Director of Pediatric Hospital Medicine at Community Memorial Hospital. And it's my pleasure to join you tonight, along with Dr. David Crownover from our Obstetrics and Gynecology Department, to discuss the COVID-19 vaccine for pregnant women, lactating women, and children. I'm going to turn it over to Dr. Crownover now to start our presentation.
Thank you. Good evening. So as she said, I'm David Crownover. So I'm one of the obstetrician gynecologists with the Department of Obstetrics and Gynecology here at Community Memorial in Ventura. And we really just wanted to have a discussion with the community about kind of special populations, meaning pregnant patients, those that are breastfeeding and the pediatric population. So just in terms of the format, I'm going to kind of give a little overview from the pregnancy and the breastfeeding standpoint, and then Dr. Shuman's going to give a presentation related to the pediatric population, and then we'll try to answer your questions that I think are being put into the system during the presentation. So we'll kind of get going. Just in terms of the discussion, this is really from my segment on this, it really, again, kind of big picture is the discussion really is around what are the risks of the virus itself. In other words, what are the risks of the COVID-19 infection in pregnant patients? And then what are the risks of the vaccine while pregnant? And then really has it been shown to be effective in terms of the vaccine in that population? And then discuss something of what people refer to as vaccine confidence. And there's a little overlap between our two talks, but they are really intended to sort of reiterate the points. So just to kind of start out, everyone's aware that there are 3 available vaccines, the Pfizer vaccine, the Moderna vaccine, and the Johnson & Johnson vaccine. So these are the ones that we're discussing. And if there are differences, we'll point those out kind of as we go. So just to kind of start out, what are the risks of the COVID-19 infection in pregnancy? So this has evolved, obviously, like everything else has evolved, but we were discussing actually just before we started, this has been an interesting journey along the way, because when we started this specifically for the infections, I remember sitting and telling patients, we don't really know much about this. And, we're a year in now, so obviously we know much more. So where we are today, the absolute risk of severe illness in pregnant women, it's low. This tends to be a young, healthy population. And so in general, that risk of severe illness is low. However, it is very clear that there is an increased risk of ICU admission, need for a ventilator, and death compared with a similar group of non-pregnant women. So if you take the similar ages, similar health status, in patients that are pregnant, they do have additional risks. Those patients that are pregnant, that are obese or have diabetes, are clearly at even higher risk of severe disease. And I think it's well known at this point, Black and Hispanic pregnant women have disproportionately higher rates of COVID-19 infection and death. And this is due to various factors. We could probably spend an hour on that talk in and of itself. But this has to do with access to care. This has to do with more chronic conditions, et cetera. But the point of all of this is when we look at the risk of COVID-19 infection in pregnancy, it is higher and more severe than in non-pregnant patients. So all of that being said, what are the risks of the vaccine in pregnancy? So everyone is probably aware that pregnant patients were not included in the trials for the vaccine. One of the reasons that we're having this discussion, similar in pediatric patients, but in the pregnant patients, they weren't included in the trials. So this is always the question that comes up. This is not, quote unquote, not been well studied, and therefore I have a fear of getting the vaccine. Valid concern. What I would like to drive home tonight, or just make sure that people have accurate information, is that this has been very closely monitored since the vaccine has been being administered. So I just wanted to run through this one. Everyone's heard this on the news. And again, the whole point of this is to get everybody accurate information. So these risks are closely monitored by something called the Vaccine Adverse Event Reporting System. And on April 13th, the CDC issued this health alert saying that there were 6 cases of this so-called cerebral venous sinus thrombosis, which is a rare type of blood clot in the brain. I'm sure people are all aware of that. And this was specifically reported in women age 18 to 49 that had received the Johnson & Johnson COVID-19 vaccine. That vaccine administration was paused. It was put on hold until this could be investigated. And after that investigation, sort of worldwide, it was found that 7 cases per million, there were 7 cases per million of this event, and the overall benefit seemed to clearly outweigh the risk of this rare event. And then on April 23rd, that pause of the administration was lifted and the vaccination was resumed. I think, again, the point that I want to make in all of that is not that there is not related to the risk, but it's related to the fact that there's clearly monitoring that's going on. And I see this as a situation where that monitoring worked. In other words, when there was a concern, it was paused. And these are situations, understand that a lot of time and effort and money, et cetera, went into setting this situation up where people were being vaccinated and there was a real push. And there was a concern and it was paused. And that gives me confidence to say if there are further concerns, it's going to be talked about, it's going to be paused, et cetera. So as far as the safety monitoring, one of the largest sort of groups that we have is this so-called V-Safe. And if any of you have been vaccinated, you probably were offered that. I participated in that myself. And this is self-reporting and it goes to the CDC. But I think it's important to know, again, that there are more than 100,000 pregnancies that have been reported post-vaccination with no safety signals observed. In other words, millions of women have gotten immunized, but over 100,000 women have gotten immunized and then become pregnant and reported back on if they had any adverse events. And that information looks very reassuring. There are over 4,700, so almost 5,000 individuals that were known to be pregnant, chose to be vaccinated, and then were followed again with this V-Safe. And again, there were no safety concerns of that. Very important study published in the New England Journal of Medicine, April 21st of this year. And this looked at 827 completed pregnancies, pregnancy and neonatal outcomes, so for mom and for baby. There were no differences in the pregnancy complications or neonatal outcomes. So those are things like miscarriages, stillbirth, so-called preeclampsia with high blood pressure, early deliveries, problems with baby, meaning congenital anomalies, or death. And again, very reassuring in terms of the data. And then in terms of expert recommendations, again, I just think it's important to know that there is a group called the Advisory Committee on Immunization Practices. And this is the group that makes all of the recommendations for immunization, childhood immunizations, adult immunizations, et cetera. There is completely separate group, Centers for Disease Control. Everyone's familiar with them now because you hear that on the news all the time. And the American College of Obstetrician Gynecologists, all independent groups, all expert opinions are that pregnant and lactating women are eligible for and can safely receive the COVID-19 vaccine. So I think that's important to know. So we know that there are more risks in pregnancy. We know that the vaccine appears to be safe. Is it effective? I'm not going to go through, I'm going to go read every word of this, and I think a lot of people have heard this already, but Pfizer vaccine seems to be 95% effective at preventing the illness in people who receive the 2 doses. Moderna, 94% effective. Johnson & Johnson, 76% effective at preventing severe or critical illness after a single dose. So they all seem to be very effective at preventing serious illness. And again, I think this may be one of the slides that's a little overlap of both of ours, but again, important to know. There was a study published in March, so March 25th, American Journal of Obstetrics and Gynecology, and this was 131 reproductive age vaccine recipients. 84 of them were pregnant, 31 of them were lactating, 16 were not pregnant. two separate academic centers and both showed same thing, that COVID-19, specifically the mRNA vaccine, so this is Pfizer and Moderna, generated immunity in pregnant and lactating women that were similar to non-pregnant women. And very importantly, I think that there was immune transfer, so of antibodies, to the neonates. So in other words, if they were pregnant and they got vaccinated, they found antibodies in baby. If they were lactating, if they were breastfeeding, then they found antibodies in baby. So both of those things are reassuring. Now, we don't have the information on how protective that is for babies, but it appears to be helpful for both mom and baby is the point of that. So last kind of part of mine is this so-called vaccine confidence. And again, I think just a few points on this, that this vaccine is new, but several vaccines have been given to pregnant and lactating women for decades. Tdap, or the so-called pertussis vaccine, being one of them. We have given that for years. We routinely give it to patients, and it has been shown to be very safe. Although not included in the original safety trials, again, I think it's important that, because that's always the question that's asked to us of, well, were the pregnant patients included? No, then we must not have information. But again, we're at a point now where we have literally hundreds of thousands of women that have been immunized and known to be pregnant at that time or become pregnant. And all of the information as far as safety goes seems to be very positive. And then again, just the fact that it's just important to know that there is this ongoing safety monitoring by these groups that are on the slide. And again, I think I'll reiterate one more time that when there was an issue, that was paused. The immunization was paused, and I think you can, should feel comfortable that that would happen again if there were any safety concerns. So, last slide for me, kind of just the summary. We know that the infection poses serious risk to the pregnant women and lactating women. There really is no effective treatment for COVID-19 that's been well studied. And the vaccine appears to have no known risk, and the vaccine seems to be very effective at decreasing the serious illness. So that's kind of my portion, and we're going to kind of switch over to Dr. Shuman's portion as well.
I think, Dr. Crownover, I think today actually I saw a report that 2 additional studies had come out reporting on safety in pregnant and lactating women. So I have a question for you. Are you recommending for your patients? Are you recommending they get vaccinated?
Yeah, I think it's a good point. And I think it's going to be one of these things. This information is going to continue to trickle in, but every piece that we have seems to be very reassuring. And so I can tell you, I started the talk by saying we were talking about in the beginning. I said they weren't included. I'm not really sure. I feel much more comfortable at this point in saying that there is a lot of information, although not in the original safety trials, in the ongoing registries, that's very reassuring. And I certainly am telling patients every day, we have a little list of things that we need to check off. Did they get their glucose test done? Did they get their swab done? And that's on my list now. Have I talked to them about the COVID-19 vaccine? Because I think it's that important to at least consider. And again, not only for mom, but probably for baby too, which segues to your portion.
Thank you so much. I just want to remind everyone that we will be doing a question and answer session at the end. Feel free to start sending those questions in while we're talking. And then at the end of this, we will do our best to get to as many of those as we can. So I'm going to move on now and talk a little bit about COVID-19 vaccines in pediatrics. And there's a lot to talk about. So first of all, I just want to talk about which vaccines are authorized for children. So right now, the only vaccine that's authorized for anyone under the age of 18 is the Pfizer mRNA vaccine. In the original studies for Pfizer, those were done with up to 30 to 40,000 people. They included children down to 16, and they were found to be both safe and effective. And then after completing that initial trial, starting the vaccination campaign, Pfizer then has continued on, as has Moderna, and I'll talk a little bit about that, to now look at studies specifically in younger children, and they're parsing these out into different age groups. So Pfizer began looking at children from age 12 to 15, and recently, as you all probably realize, the FDA made an EUA, or emergency use approval, for the Pfizer vaccine for children 12 to 15. Moderna, in addition, is doing trials of children under age 18 all the way down to age 6 months. It hasn't yet been completed. Little information for you here. There's one called the Teen Cove study that's looking at children 12 to 17 for the Moderna vaccine, and that's including about 30 to 100 patients, 2/3 of which will get the vaccine, 1/3 of whom will get the placebo, and then their Kid Cove study, which is age 6 to 11, and that's ongoing. So far for the Moderna trials, they're seeing side effect profiles that are similar to adults. And the same can be said for the Pfizer vaccine. So Pfizer looked at 12 to 15, and they're now separately looking at children age 6 to 11, and then they'll look at children age 2 to 5, and then 6 months to 2 years. The Pfizer vaccine trial that was done in the age group from 12 to 15 included 2,260 participants. They split that evenly between placebo, meaning children who didn't get the vaccine, and children who did get the vaccine. During that trial, 18 cases of COVID-19 occurred. All of those occurred in the placebo group, meaning none of the children who got the vaccine developed COVID during that time, but 18 of the approximately 1,100 children who didn't get the vaccine did catch COVID. So in the trial, that shows 100% efficacy for preventing COVID. Now, do we expect there to be 100% efficacy in the real world? No, but we do think this points to likely having similar efficacy for children that we're seeing in adults, so greater than 90% efficacy in real world protection against COVID-19 infections. Just so everyone knows, I know the news loves to talk about breakthrough cases as if they're happening all over the place, but worldwide, we've had just 10,000 breakthrough cases of COVID for over 100 million people who've been vaccinated. That means 1 in 10,000 people who've been vaccinated have gotten COVID-19. Of those 1 in 10,000, 30% of those people were completely asymptomatic, had no symptoms at all. So it's actually very, very, very minute number of people who are breaking through with infection. And there's no vaccine on earth, or there's nothing on earth in general, that's 100% effective. Not your seatbelt, not anything. Don't stop wearing your seatbelt just because it doesn't always protect you from being harmed in an accident. Okay. So in this Pfizer vaccine trial, what did we see? In addition to protecting the children who are in the vaccine group from getting infected, we saw that kids had very good, actually better antibody responses than adults did, meaning they mounted higher antibody levels and more levels of protection. And their side effect profile was very similar in this initial trial to what we were seeing in adults. So fever, achiness, et cetera, et cetera. All of those study participants will be monitored for an additional 2 years. And again, they have even more ongoing trials to parse out younger age groups. We're hoping that they'll approve the vaccine for children from 2 to 11 as early as September of this year. So how do we approve medications, vaccines, which are usually studied in children, for children when the initial large study was done in adults? So shockingly, what many people don't realize is that until recently, most of the medications that are used in pediatrics have not had any studies done in children at all. In 1994, realizing that this was not ideal, the FDA enacted some laws that do now require that drugs that are going to be used in children be studied in them. But what does this mean? So for many years, all of us have been using things in children that have had zero data. I like to use this as an example. Ibuprofen, which we all think of as Motrin, which is bought over the counter. People use it, we all use it, we prescribe it as pediatricians, families, you guys are using it at home for children. Until a few years ago, had absolutely zero dosing data based on any trials for children under the age of 2. So we didn't used to study this at all. Why is that reassuring? Well, that's not what we're doing anymore. So we used to actually approve things for kids with zero trials. In contrast, we're approving these COVID-19 vaccines only after adequate trials have been done. Now, for some medications, studies looking at transferring safety data for adults down to children use as few as 100 or less participants and are actually able to transfer safety data down to say, like, this was safe enough in adults, we only need up to 100 children to transfer safety data. We're obviously using more than that in COVID-19 vaccines, but again, just to reassure people that while this may not seem like a large sample size, it is actually more than adequate for us to try to evaluate safety in children. Not only are we looking at safety in children, we're not actually treating all children the same. We're not saying your 2-year-old is the same as these 13-year-olds. We're looking at each age group independently in order to assess, is there a difference in a safety profile for any specific age group? And then this is a busy slide, but for anybody wondering how we decide whether a trial is going to be done or how it's done for extrapolating data from safety trials on medications down to children, this is actually what is used. This is the algorithm. It's called the Pediatric Study Planning and Extrapolation algorithm, and you can find it online to get a sense of how do we decide how to study those things. So let's talk a little bit about COVID infections in children in the US so far. So thus far, about 3.78 million children have been infected, and more than 300 have died. Some people say up to even 500 because maybe it's being underreported deaths that are occurring that haven't been attributed to COVID that maybe were. I heard someone today say, it's only 300. Well, only 300 when it comes to children. My take is children aren't supposed to die at all, right? That's not what we expect. And certainly we shouldn't accept children dying from something that we can prevent. That's my personal take. While initially I'm sure everyone knows that children were actually making up a very small portion of the COVID infections in the US, about 2 to 3%. Currently, our total numbers are coming down, but of those cases that are occurring, children now make up about 24% of the cases. Why is that? Well, likely that is because we're vaccinating actually our older populations, and so they are less at risk. They are catching it less. Children who haven't yet been vaccinated are still at the same risk, and so now again, they're making up a much larger portion of the current infections that are occurring. And so then why are we here tonight? Well, really, so why should we vaccinate children for COVID to protect them? Again, most people probably know our initial studies looked and said children in general, and this is true, children usually have pretty mild cases with COVID. They're often not hospitalized. They're often even asymptomatic. So why would I bother subjecting my child to some sort of invasive procedure, a shot, anything like that, when they're not likely to get severely ill with this disease? So let me go through why it's still valuable and why I would recommend vaccinating children for COVID. So number one, herd immunity, right? So we've all heard this. It's a kind of catchphrase in the news. Herd immunity is the number or percentage of the population that needs to be vaccinated against a disease for us to basically stop it from running rampant in our population. And it's predicted for COVID-19. Initially, we thought about 70% of the population would need to be vaccinated, but now with the new variants that are coming out, they're saying up to even 85% of the population needs to be vaccinated in order to prevent that spread. Well, for better or for worse, children, so people under the age of 18, make up 24% of the US population. So we really can't get herd immunity if we're not vaccinating any children. Children can pass the disease on, right? So the vaccine is very effective, but it's not 100% effective. Your child can catch it. They can pass it to grandmother, grandfather, immunosuppressed people, people with cancer, people who can't get vaccinated. And anytime we talk about things like vaccination, we're talking about protecting ourselves, but we're also talking about our community, right? So responsibility to those around us, whether it's our family, our friends, our neighbors, other children in school. So herd immunity is definitely a good reason for us to be vaccinating children. For me, I think the most important reason to be vaccinating children is to protect against this disease process called MIS-C. That stands for Multisystem Inflammatory Syndrome in children. And again, many of you have probably heard about this on the news. This is something that occurs post-COVID, typically 2 to 5 weeks after the infection. And it's basically an immune response later on to the virus that actually can be incredibly severe. So what it does is it causes inflammation in multiple organ systems. So basically any organ system you can think of, the heart, the eyes, the liver, the GI tract, the kidneys. So far in the US, we've had about 3,100 cases reported. Of those 3,100 cases, 36 children have died. So that means 1 in 100 children who develop this have died. That's not a small number, if you ask me, as someone who cares for children. Again, it occurs about 2 to 5 weeks after COVID infection. And I think the most important thing to know when you're thinking about this is what we have found is that the risk of MIS-C has absolutely nothing to do with the severity of an initial COVID infection. In fact, up to 75% of the children who developed MIS-C were completely asymptomatic with their COVID infection. So it doesn't matter if your kid got just the sniffles, got no symptoms at all, their risk for this severe inflammatory syndrome is exactly the same. Technical difficulties. Okay, and last but not least, long-haul COVID. So much like adults, where we're finding that months and months later, people are still suffering from symptoms, brain fog, fatigue. Children also can develop long-haul COVID. And so again, children should be healthy, happy, running around, alive, and protecting them from long-term chronic symptoms. And we don't really know how long long-haul COVID is going to last or what the long-term implications of that are going to be. So again, for me, that's another reason to think about vaccinating our children. This just goes a little bit more into MIS-C. Again, we talked about it's a severe inflammatory syndrome of multiple organs. Up to 40 to 50% of children who develop MIS-C will have myocarditis. And that will be an important statistic to think of later when we talk a little bit about the current reports coming out. Most children who develop MIS-C will need to be hospitalized. Of those, 60 to 80% will need to be in the intensive care unit. For the younger age group, newborn to 4-year-old, it's a little bit lower, about 40% in the ICU. But for any parents who are watching, I can imagine that for you, there's a 0% chance you want your child to have to be in an intensive care unit. About a quarter of those children ended up needing to be on a ventilator. So that's a breathing machine because they're in respiratory failure, lung failure. 80 to 85% of the cases affect the heart in some way. So again, we said about 44 to 50% develop myocarditis, but it can affect the heart in a multitude of ways. That can include coronary aneurysms, so basically weakening of the wall of the blood vessels that serve the heart, electrical abnormalities and arrhythmias, and then decreased function for the heart. And again, so about 30 to up to more than 50% develop some sort of cardiac dysfunction, meaning the heart's failing, it's not pumping appropriately, and then they often need medications to support their blood pressure. And then again, even with all the possible treatments we have right now, about 1 in 100 children who develop this syndrome will end up dying from it, which is not okay. So, and then I just should go back to this slide because to me, the most important thing is the only way to prevent MIS-C is to not get COVID. So how can we prevent your child from getting COVID? We can vaccinate them. Okay, so what don't we need to worry about when we're talking about these vaccines? Let's talk a little bit about fertility because that's some misinformation that has spread on the internet, and I want to touch on that for anyone who's concerned about it. So that's probably to me the most common misinformation that I've seen, that there's an issue regarding either future fertility or miscarriage with the vaccine. And where that started is someone in Europe claimed that the spike protein, and the spike protein is what the mRNA vaccine codes for, shares significant similarity to a protein called syncytin 1 that is a protein present on the human placenta. And the idea that this person put out there was that these were super similar, and so when your body created antibodies to the spike protein, those antibodies would cross-react, bind to syncytin 1 on the human placenta, and would affect fertility or cause miscarriage. So in reality, the mRNA for spike protein in the vaccine shares a sequence of just 4 amino acids with syncytin 1. And just for reference, the syncytin 1 protein is made up of 538 amino acids. They share just 4. And I want to go into this a little bit more. So a little sciencey for those of you who are interested. If you want to take me at my word, not to worry, you can tune out for a second. But for those of you who want to know why I'm saying this, a little information behind it. So just a little information, amino acids, those are what are the building blocks of how we make proteins. There are only 20 amino acids at all. That's all that exists on this earth. So the entire world, everything we look at, every protein you can imagine, the chicken you eat, my skin, any protein you can imagine, they're all made up of some combination of these. And so they all share some similarities. It's impossible that any two proteins being compared would share 0 similarity. For there to be cross-reactivity between any two proteins, they need to share more than 35% identity over 80 amino acid stretches. So over 80 amino acids, more than a third of those 80 amino acids need to be the same for there to be cross-reactivity. Otherwise, they do not cross-react. So we'll go back to saying these two proteins share just 4 amino acids total. So that's not 35% of an 80 amino acid stretch. So the short story is SARS-CoV-2, which is coronavirus, the COVID-19 virus, the spike protein for that and syncytin 1 are not, absolutely not cross-reactive. And just to get super duper sciencey on y'all here, this is actually on the top of your screen is the coding, all of the amino acids for the syncytin 1 protein. And on the bottom is the sequence of amino acids for the spike protein. And I'm not sure if you're able to appreciate those tiny highlighted areas, but those tiny highlighted areas, it's 3 letters on the top and 3 letters on the bottom. That is the similarity between the two. The entire remainder is dissimilar. So again, just to tell you, this is an absolute myth. It is misinformation. Please be reassured that this is not an issue when it comes to COVID-19 vaccination. When we get a real life infection with COVID-19, we make antibodies to spike protein. If that was cross-reactive with syncytin 1, we would actually be seeing real life infection cause these same issues. And we're actually not seeing that, okay? Again, just to reiterate what Dr. Crownover had mentioned, as of May 24th, 2021, more than 118,000 women had reported into VSafe, the vaccine surveillance program. More than 118,000 pregnant women had reported into that, and the outcomes of those pregnancies have been no different between vaccinated and unvaccinated women. Now, we definitely do see an increase in miscarriage with COVID-19 infection that is not being seen with the COVID-19 vaccine. And why is that? That's because anytime a pregnant woman gets a fever or any infection, she's more likely to miscarry. So that's not unique to COVID-19. That's with almost any viral infection that can give you fever and make you very ill. But we are not seeing that with the vaccine at all. There is no cross-reactivity between the antibody for the spike protein and the antibody for syncytin 1 on the placenta. Okay, so what about shedding spike protein after vaccination, right? This came out that people were saying, oh, someone got their vaccine and then the women around them, their menstrual cycles were changing because you were shedding spike protein. Okay, we do not shed spike protein after vaccination. That's a biological impossibility. So let's talk a little bit about why, so you don't just take me at my word that I say it's not possible. So number one, the mRNA from the actual vaccine is broken down very rapidly in your body. What persists is not the mRNA, not even the spike protein, but the antibodies that we have. So the antibodies persist. That's what gives us immunity. The spike protein by itself is not the same thing as the whole live COVID-19 virus, okay? In order to shed a virus, you need to have live circulating virus. And the mRNA vaccines and the J&J vaccine, none of them contain live virus, okay? None of the COVID-19 vaccines that are here in the States, and I don't actually believe any of the COVID-19 vaccines that are currently approved around the world contain live virus. Without live virus, you cannot shed viral particles or spike protein. So again, just not biologically impossible, okay? Again, I like to always say, if this could occur, we would be seeing this happen with women who have COVID-19 or women who are exposed to people who have COVID-19 infection, because people who have actual COVID-19 infection absolutely are shedding the virus, right? That's how they infect other people. So if this was a possibility, COVID-19, the virus itself, when someone was infected, would be altering the menstrual cycles of women around them from protein shedding. That is not happening. And we do not shed protein just from the vaccine. That is, again, absolutely biologically not possible. Okay, so the last part of my talk, just to talk a little bit about these current or recent reports that are coming out about the possibility of a link between myocarditis and the COVID-19 vaccination. And of course, this is something I'm sure that people have concerns about. So I want to touch base with it. So first, let's talk a little bit about what is myocarditis. So that just describes inflammation of the muscle of the heart that can affect the heart function. There are multiple causes for myocarditis. Viruses can cause it. That's actually the most common cause. There are medications that can cause it. Bacterial infections, parasitic infections, a multitude of things. It can be autoimmune. At baseline, on a regular year, So we're separating out before COVID-19 even occurred. We saw about 10 to 20 cases per 100,000 people every year of myocarditis. That is normal for us to see based on all these other causes that we know can create myocarditis. As an example, in 2017, 3.1 million cases of myocarditis were reported in the US alone. At baseline, it affects males twice as often as females, and that's important because in these reports, you're gonna see that they're seeing this more often in males than in females, and that goes along with what we see with natural myocarditis from natural infection from causes we're expecting to see that from. And common viral causes for myocarditis tend to occur often in the summer and fall. So viruses that circulate at this time of year actually are commonly known to cause myocarditis. So far, we've vaccinated between 4 and 5 million children between the ages of 12 and 17. Between the ages of 12 and 15, so that's been a little more recent, we've vaccinated more than 500,000 children. In the US so far, we have had reported what's called a quote unquote handful of cases. And I did my best, guys, to try to find exactly how many cases have been reported in the US. In April, they'd had 14. I don't know what the exact number is today. It's being said as a handful. I can tell you in Europe, they've looked at this. They've seen a total of 107 cases. When they do the numbers, looking at how many vaccines they've given, and those 107 cases, if, and we'll get to this, if the vaccine was linked to that, that would mean that for every 175,000 doses of vaccine, they're seeing 1 case of myocarditis. And in Israel, a study came out today saying that they are seeing this too, and they think it may be related based on their data. That doesn't mean it is, but that's what Israel currently is reporting for themselves. And based on their data, they're seeing that for about every 50,000 doses of vaccine, they're seeing 1 potential case of myocarditis. So again, they've seen 110 cases of myocarditis and given I want to say 100 million vaccines or something like that. So does this mean, all these reports, does that mean that the COVID-19 vaccine causes myocarditis? No, does not mean that. Doesn't mean it doesn't, just means the jury is still out and we're closely looking to see if this is the case. So again, normally we expect to see 10 to 20 cases per 100,000 of myocarditis. What we're seeing now, these reports, is actually a lower number than we would expect at baseline, okay? That also doesn't mean the vaccine protects us from it, right? Just means so far these cases don't even reach baseline numbers of what we would expect to be seeing of myocarditis on a normal year, and it certainly has not exceeded our normal baseline cases we would expect to see. So that's reassuring. Maybe these are just our normal summer viral infections causing myocarditis as they do, and it just happens that we happen to be giving this vaccine now. So what do you need to know as a parent to make an informed decision? Or if you're a teen watching, to have a conversation with your parents about whether you want to be vaccinated. So again, the rates of myocarditis that they're reporting are not higher than the usual number of expected background cases. Short version, there's not an increase in cases of myocarditis since introducing this vaccine. And I think an important thing to remember always is that correlation is not causation. Just because 2 things happen close together in a time frame, that doesn't mean one thing causes another, okay? But that's what we're looking at now. This could be just correlation, again, coincidence, like it happens to be, this is the time of year that the viruses that tend to cause myocarditis are circulating and we're seeing it. Or it could be that there is a true link, and we are actively looking into that. And so I'm gonna talk a little bit about one other thing. So it's important to know that these cases, they've all been mild and they've all recovered on their own. It's also important to note that natural infection, meaning getting COVID-19, the virus, absolutely does increase the risk of myocarditis. And they've done autopsies and shown that about 1 in 20 patients who had COVID-19 had signs of myocarditis on autopsy. Again, we talked about MIS-C, where these kids, about 40 to 50% of those kids who get MIS-C will have myocarditis. So what all of the different groups are saying, the ACIP in Europe, in Israel, everyone is saying that if it turns out this is a true link, we would still recommend the vaccine because the risk of this from the vaccine is low and actually lower than the risk from the infection itself. And then I just want to actually reiterate what Dr. Crownover said, which is to say that To me, this is an indicator of how effective our surveillance for vaccines, not just this vaccine, all vaccines, because we use these same surveillance systems for all vaccinations, okay? If we can pick up a potential safety signal when it is occurring at less than the expected background rate, that means we have an incredibly effective surveillance system, okay? So just because there's a potential signal doesn't mean there's an actual safety issue, but it means it gives us the ability to pause when we need to pause, to look into it, to make the right recommendations for our patients, for our population. And again, to me, that should make you feel better about our surveillance. The fact that we can pick up just so few cases for blood clots with J&J, I think they had 6 cases or 7 cases in millions of doses. And the fact that we could pick 6 or 7 cases up per millions of doses is absolutely incredible testament to how good our surveillance is. So finally, in summary, because I talked for a long time, I just want to say, so these vaccines are being well studied for safety. Don't fear that we are cutting corners. We are not cutting corners when we're looking at safety for these vaccines in children. Again, despite having often mild or asymptomatic cases, catching COVID-19 puts children at risk for multi-inflammatory system syndrome for children, which is severe. 1 in 100 children who get that will die. That is not an insignificant number. And many of those kids will have these cardiac effects that we're talking about being worried about in the news. Many more of those kids will be affected with that if they catch COVID. They absolutely do not impact fertility. That is not something you need to be worried about. Will my daughter be able to have babies in the future? That's not a concern. And then again, for myocarditis, the jury's still out, but so far our rates are not higher than we would normally expect. Again, and the risk of COVID-19 causing myocarditis is absolutely real. So again, I'm here to give information. I want you to be able to make an informed decision. Would I encourage vaccination for children? Absolutely. I hope I've helped you tonight to make a decision for your family that feels right. And now we'll go to taking some questions.
I think you're up.
All right, so our first question. My grandson is being treated for autism. He's on multiple medications. Is it safe for him to be vaccinated while taking these meds? So that's a great question. What I would recommend is so first I would say, obviously people who were in these vaccine trials, many of them are on medications. There's no signal that there's any cross-reactivity with any specific medications. For anyone who is on medications wondering whether it's something related to your child's autism, ADHD, or for adults who are on medications, if you have questions, I would talk to your physician specifically about your medications. If you're my patient, give me a call. We have telemedicine appointments, as y'all know. I'm happy to talk with you on the telephone about it. But I would say there should be no concern really for taking medications and getting the COVID-19 vaccine. Dr. Crownover?
Right. I think we may skip this one. Does the vaccine affect young females' menstruation or fertility? So I think we've said no.
Okay.
The next one up is, as a breastfeeding mother, I'm concerned about the possibility of COVID-19 vaccine having a negative effect on my nursing baby. Has anyone looked into this? I think the question is, does it affect the child? And again, Dr. Shuman did a good job at addressing this, but my answer would be, which I think she kind of spoke to, really the only thing that is passed in the breast milk is the antibody. So it's not the vaccine, it's not the virus, it's really only the antibody. The same way that antibodies, for example, if a lactating mother got influenza and they develop antibodies and they pass into the breast milk. So only the antibodies are passed in the breast milk. So it should not affect the baby at all. And may be helpful, I should say. Yeah.
So I touched a little on this. So someone's asking how many children participated in the trials, stating they'd be more comfortable if the groups were significant, which I completely understand. So again, in the Pfizer trial for the younger kids, we looked at about 2,200. The Moderna are looking at over 3,000. And again, that's more than an adequate number in order to extrapolate using the initial safety data that we have. That's more than an adequate number of children to look at to be able to confirm safety in that group. So.
Next one, can you explain how the antibodies from the Tdap vaccine and the COVID vaccine get to the fetus through the placenta, but the vaccines themselves, I'm assuming, do not. So this goes back to just the biology of you get an infection. We'll start with infection first. And so a virus enters your body, you develop these antibodies, and that's sort of what protects you, and the virus sort of gets destroyed and goes away. For the vaccine, it actually works exactly the same way. So the vaccine, even though it's not a live virus for Tdap and for COVID, this is a piece of the virus or a particle of the virus, a protein-like virus, protein-like structure. And you develop these antibodies. And again, it's really the antibody that crosses the placenta and enters baby. But that vaccine does not cross the placenta. Technically, how to look at that is it has to do with the way, and I guess we don't want to go into a lot of detail, but the way anything crosses the placenta. So it has to do with the size of it. It has to do with whether it's sort of water soluble or fat soluble, if you will. So there's a lot of factors on why that is, but suffice it to say that antibodies cross, but the vaccine does not cross the placenta.
Yeah,
so hopefully that answered the question.
Yeah. Okay, I have a newborn and I'm planning on getting vaccinated. Awesome. I'm very pro-vaccine, as you can all tell. I'm sorry. If I have side effects from the vaccine, fever, etc., should I stop breastfeeding until symptoms subside? No, absolutely not. You breastfeeding with a fever, so any more than if you got sick, you don't need to worry about breastfeeding when you're ill. You're not harming your child. Again, if anything, what you're doing is you're passing your antibodies onto your baby and protecting them when you're sick from what you have. Or in this case, you're able to start to potentially protect them from COVID because you're passing antibodies onto them. So there's nothing about your fever, your muscle aches, or anything like that from this. Nothing about your immune reaction that would harm your baby for you to breastfeed. So please keep on breastfeeding if you're already going at it.
Right. The next question was, what is your opinion for a woman who is interested in getting pregnant and has already had a documented case of COVID-19? Should she get vaccinated? So I guess two questions. So if she has had the virus, is there any reason to wait, etc.? And I think it's sort of the same answer. There isn't really any information that would say there would be a need to wait. In fact, she's probably developed an immune response, has antibodies, and should feel comfortable attempting to get pregnant. And I think the second part was, should she still get vaccinated even if she's had the virus? And most people say the answer to that is yes, with the thought being, and interestingly, a lot of these studies are saying the immune response that we get from the vaccine is greater than the infection itself, which is interesting. But the big issue is that we don't know how long that immunity lasts from the infection itself. A lot of these things, again, like influenza, we always kind of compare those because we have much more experience and information. We sort of know how long that immunity is going to last, but for COVID-19, we really don't. So the idea is it would be better to have that additional immunity than for that immunity to wane and then be susceptible again. So that's a long answer to say, even if you've had the virus, we would still recommend getting the vaccine.
Okay, how often does MIS-C happen with other viral infections? And the answer is 0. This is the first time we've ever actually seen MIS-C. So when we were first seeing cases, they were comparing it to something called Kawasaki syndrome, which is an inflammatory syndrome, and they do have some overlap in terms of the symptoms, but they are not the same thing. We have actually no idea what causes Kawasaki syndrome, but as far as MIS-C, there are 0 other viruses that have ever caused this. This is the first time we've ever seen this. It's a brand new thing. How can I schedule an appointment for my 12 to 17-year-old to receive the vaccine? Couple options. Most of the time, the Pfizer vaccine is difficult for them to carry in doctors' offices because that's the vaccine that requires ideally that really sub-zero, like negative 80 degree freezer. And so many doctors' offices don't have that. But you can obviously call your individual physician office and see if they're going to be offering it. But otherwise, probably the easiest thing is you can schedule for children the same way we're scheduling for adults. I think in California, the website is myturn.gov, and they're giving them at any of the pharmacies that carry the Pfizer vaccine is giving them to children from 12 to now 15. They were giving them 16 and above before, so 12 to now 15. I should say, I want to pause the questions. I wanted to let everyone know when it comes to the myocarditis, I forgot to mention that most of the cases they are seeing are in males and males older than 16. So actually not more rates since we started vaccinating younger kids. And I think that's an important thing to say. And I thought of that just now because I'm talking about scheduling for these different age groups. The cases are actually being seen in older teenage males and older adolescent and men in their 20s, not really in younger men for the most part. Okay, sorry about that. Is the vaccine dosage the same for children? So that's a great question also. For the Pfizer vaccine, it is. For the Moderna trials, they're actually, I think, looking at lower dosing, and that's part of what they're doing now in their trials. And that kind of tags on as well. If it turns out that these myocarditis cases are related to the vaccine, so if that actually turns out to be a true association, things that we can look into would be things like lowering the doses on the Pfizer vaccines and giving a smaller dose than we give adults, or spacing out the doses and seeing if that were to lower the risk. And again, that's an if. That's if these are related. All right. Any other questions? What preservative? That's a great question. So what preservatives are used in the COVID vaccine and how does it impact the body? There are actually no preservatives in the COVID vaccine. So the COVID vaccine has the spike protein, it has some sugars, it has lipid nanoparticles, which is a fancy way for saying fats. That's what protects the mRNA, but there are really no preservatives in it. Okay, so I think we're getting close to the end. We may have time for like one or two more questions and then we're gonna have to close it up. No, we have run out of our time, guys. So I just want to say thank you to everybody for joining us this evening. I hope we've been informative. Dr. Crownover, thank you to you.
Yeah, thank you as well. And the whole goal obviously was just to provide information to make an informed decision on getting the vaccine. And so hopefully we've provided you with accurate information. So thank you for joining us.
Have a great night, everyone.